Good afternoon, my name is Mariah Peterson and I will be presenting on peptic ulcer disease. Introduction. Cause of peptic ulcer disease is associated with H. pylori and the use of NSAIDs. As of 2019, the prevalence of peptic ulcer disease is 8.09 million, which is a 25% increase since 1990, with Southeast Asia having the highest rate. The burden to the healthcare system is roughly estimated to be $3.4 billion. The at-risk population includes males and African Americans. Less affected individuals include those with higher incomes. The pathophysiology includes a defect in the gastric or duodenal mucosa, a malfunction of the secretion in the defense mechanisms of the gastric mucosa. These can be disrupted specifically by H. pylori or NSAIDs, which inhibit prostaglandin synthesis. H. pylori is a spiral-shaped gram-negative bacteria and can adhere to the gastric epithelium and proliferate. The route is either fecal or oral and can be associated with domestic cats. Clinical presentation: subjective, and patients will report with upper abdominal pain and hematemesis. The hallmark sign is abdominal pain that becomes worse with eating. Patients may also report bloating or abdominal fullness. The objectives include abdominal pain upon palpation and weight loss. Some warning signs to keep in mind include progressive dysphagia, GI bleeding, iron deficiency anemia, and emesis that does not go away. Diagnostics include an EGD, which is a gold standard for diagnosis. A barium swallow exam can be completed if the patient cannot have an EEG or does not tolerate it. Labs to include a lipase, amylase, liver function test, stool sample, CBC, and CMP. Note, if the CBC and CMP are normal, then that usually implies that bleeding is not occurring, but if they're abnormal, then that is something that needs to be considered. Urea breath test will be positive because there is urase, which is an enzyme secreted by H. pylori and is exhaled by the lungs. Differential include H. pylori, gastritis, cholecystitis, and chronic pancreatitis. And you want to consider any of these when the patient presents with abdominal pain. Differential rationale for the abdominal pain and the 4 differentials listed before include H. pylori. Again, the presenting symptoms: pain becomes worse after eating. Gastritis, abdominal pain, they will have nausea, vomiting, hiccups, and loss of appetite. Cholecystitis will be upper right quadrant pain with fever and leukocytosis with positive Murphy sign. And chronic pancreatitis will have abdominal pain and stenorrhea. Management, so if the diagnosis is related to H. pylori, then the treatment will be with a PPI, mainly omeprazole, and then antibiotics. The main ones are clarithromycin, metronidazole, and amoxicillin, and then continued maintenance with a PPI. And then if it is due to NSAID, then obviously the patient needs to stop using the NSAID, treat with omeprazole again, usually 20 to 40 milligrams daily for 4 to 6 weeks, and then maintenance PPI if needed. So implications and guidelines. So management, prevention, diagnosis, and treatment in the F&P role. The use of PPIs to prevent bleeding or further damage, or for NSAID-related PUD. Diagnostics, again, is the EGD, which is the gold standard, and then treatment of H. pylori. The 2 first-line antibiotic therapy includes amoxicillin and clarithromycin. The Christian worldview includes Those who have peptic ulcer disease can be very frustrated, as it is a condition that takes time to diagnose and figure out, and then also takes time to treat. And so patients may be very frustrated, as they may have been in pain for a while, not able to eat very much food. So things to consider. As providers, we need to be able to show compassion and meet them in the midst of their struggle. And Jeremiah 30:17 states, but I will restore you to health, and heal your wounds, declares the Lord. And on that note, I will conclude my presentation. Thank you.